Australian Health Law, 2018. Sonia Allen and Meredith Brett Blake. Page 556. Observations regarding risk of harm as the basis for involuntary detention. In most areas of health law, consent is regarded as a fundamental prerequisite for health care and treatment. In mental health law, however, the legislation has traditionally provided that in certain circumstances, the care and treatment of a person who has a mental illness or disorder can occur without the consent of that person. This care and treatment has included detention in a hospital, ordered engagement in treatment and care in a community setting, restraint or seclusion against their will, and the administration of medication and treatment which has in some instances been refused by the person. Arguments that pertain to preventing self-harm or harm to others are most often used to justify detention, restraint, seclusion, or forced treatment. However, the question becomes whether there exists an evidence base for such arguments. In the US, the MacArthur study is often quoted to support rejecting the detention of people in hospital based upon notions of risk to others. The strongest conclusions to be drawn from that study, which were debated and clarified over years, were that violent risk attributed to people with mental disorders vastly exceeds the actual risk presented. Indeed, for people who do not abuse alcohol and drugs, there is no reason to anticipate that they present a greater risk than their neighbors. The predictors of violence from people with mental disorders are more similar to than different to predictors for the population as a whole, including alcohol and drug abuse. Violence in this population only rarely results in injury or death, and generally does not involve the use of weapons. People with mental disorders are less likely than people without such disorders to assault strangers and to commit assaults in public places. In the UK, the Royal College of Psychiatrists has noted that there is a small but significant association between some types of serious mental illness and a propensity to violence or homicide. But the overall contribution of mental illness to the incidence of serious violence in society is slight. Whether or not there is a higher risk of violence depends on the diagnosis, the nature and severity of symptoms, whether the person is receiving treatment and/or care, whether there is a history of violence, gender, and the social, economic, and cultural context of the patient's life. A person's aggression can also be associated with the side effects of medication. All acts of harm to others perpetrated by patients with mental disorder are not primarily related to their mental illness, once substance misuse is taken into account. Bernadette McSherry, an expert in mental health at the Social Equity Unit at the University of Melbourne, states, "The risk of harm criterion may be criticized for being discriminatory because it singles out those with mental impairments for preventive detention, when other groups who may be at high risk of harming others are not. The focus on risk of harm in mental health laws has contributed to significant prejudice and discrimination towards people with mental health problems. In fact, people with mental illness or intellectual disability are also more likely to be victims of violence than there are to be perpetrators. In regard to risk of self-harm, particularly suicide, across all age groups, genders, and in a wide range of geographical locations, several diagnoses of mental illness, including affective disorders, schizophrenia, personality disorders, and childhood disorders, and a history of psychiatric treatment in general, have been established as risk factors for completed suicide. When conditions such as schizophrenia and borderline personality disorder exist, suicide risk appears to be elevated around the time of the first diagnosis. For bipolar disorder and schizophrenia, the elevated risk of suicide is further exacerbated by risk factors such as a history of suicide attempts, other psychiatric diagnoses, drugs or alcohol misuse, anxiety, recent bereavement, severity of symptoms, and hopelessness. Interestingly, little, if any, evidence supports assumptions that involuntary treatment of people suffering from mental illness or disorder saves lives. That is not to say that treatment is not important. Rather, we need to look at what type of treatment is beneficial and how best to achieve outcomes that actually improve a person's mental health. Australian legislation. Movement towards a capacity/preference-based model for intervention. In the section of this chapter detailing Australia's international human rights obligations under the CRPD, and also non-binding statements such as those issued by WHO and the UN, the importance of equality before the law of persons with a disability, including those experiencing mental illness or disorder, has been emphasized. This clearly requires that such persons have a right to self-determination, which may require the provision of access to support, so the person is able to exercise legal capacity, liberty, and a right to live in the community with choices equal to those of others, including where and with whom. To this end, the International Disability Alliance state, people with disabilities have the right to refuse medical or other interventions that they consider harmful or do not want for any reason. It is a human right to preserve one's physical and mental integrity, irrespective of the opinions of medical professionals about the desirability of an intervention. Intentional interventions that disrespect this right may amount to torture or cruel, inhuman, or degrading treatment or punishment. CRPD Articles 3, 12, 15, 16, 17, and 25 are relevant. At common law, it is clear that a person is entitled to make free and informed, autonomous decisions about medical treatment provided they have the capacity to do so. It is notable that in the last several years, a number of Australian jurisdictions have introduced new mental health legislation which has made some progress towards changing the traditional approach to the care and treatment of those with a mental illness or disability. Such changes are more aligned with international and common law. For example, in Western Australia, Tasmania, and Queensland, a person may no longer be the subject of involuntary detention or treatment if they have the capacity to refuse this. Under the Tasmanian legislation, an adult is taken to have the capacity to make a decision about his or her own assessment or treatment, decision-making capacity, unless it is established on the balance of probabilities that he or she is unable to 1. Understand information relevant to the decision, or 2. Retain information relevant to the decision, or 3. Use or weigh information relevant to the decision, or 4. Communicate the decision, whether by speech, gesture, or other means. While evaluation of whether, without treatment, the mental illness will or is likely to seriously harm a person's health or safety, or the safety of others, remains, other factors must also be met. That is, such risk must be coupled with the condition that the person does not have decision-making capacity. In addition to criterion that treatment will be appropriate and effective, and cannot be given adequately except under a treatment order. This indicates a movement away from involuntary detention and/or treatment based on an assessment of there being a risk of harm to the person or to others. It is also notable that in the new Victorian and ACT legislation, there is reference to the need to seek the informed consent of that person in relation to proposed involuntary treatment. In relation to this shift, Callahan and Ryan state that capacity becomes a fulcrum for coercive psychiatric treatment and people with mental illness. People who are competent to make their own treatment decisions will not be able to be treated against their will. They conclude that such changes represent the beginning of a new era of human rights prominence in Australasian mental health law. However, several jurisdictions, New South Wales and the NT, retain the risk of harm criteria as being sufficient grounds for the detention and forced treatment of persons with a mental illness. As noted above, the continuing use of the risk of harm criteria, without reference to the person's capacity to refuse treatment, or their ability to be supported to make a decision to refuse treatment, is contrary to Australia's obligations under the CRPD. Further, controversy remains in relation to the use of restraint and seclusion in psychiatric settings. On the 1st of February 2013, the United Nations Special Rapporteur on Torture, UN Mendez, called for an absolute ban on all coercive and non-consensual measures, including restraint and solitary confinement of people with psychological or intellectual disabilities, in all places of deprivation of liberty, including in psychiatric and social care institutions. Mr. Mendez urged revision of all domestic legislation that allows for forced interventions. As noted above, mental health legislation in Australia continues to allow these measures, albeit in increasingly limited circumstances. Increased emphasis upon recognizing the human rights of persons with mental illness and working towards ensuring they are comprehensively protected. Human rights requires that persons with mental illness and disorder are given equality before the law. This is particularly important in addressing discriminatory practices, as well as emphasizing capacity rather than the risk of harm in the operation of treatment frameworks. Moving away from involuntary treatment and cruel and inhumane practices should be complemented with, among other things, a move towards addressing societal and structural risk determinants of health, enhancing individual psychosocial protective factors, developing family and community connectedness, and developing national and specific strategies in suicide and prevention. Law and policy clearly has an important role to play in what needs to be a multi-sectorial approach to the prevention and treatment of mental illness and disorder. The MacArthur study is by F. Torrey, J. Stanley, J. Monaghan, H. J. Stedman, and the MacArthur Study Group. The MacArthur Violence Risk Assessment Study Revisited. 2 views 10 years after its initial publication. In the journal Psychiatric Services, 2008, volume 59, bracket 2, page 148 to 152. As for the UK citation, Royal College for Psychiatrists, Rethinking Risk to Others in Mental Health Services, Final Report of a Scoping Group, College Report CR 150, 2008, Royal College of Psychiatrists, London. And also J. Monaghan, H. J. Stedman, E. Silver, et al., Rethinking Risk Assessment, The MacArthur Study of Mental Disorder and Violence, Oxford University Press, 2001. Bernadette McSherry, Time to Rethink Mental Health Laws for Treatment Without Consent, 5th of October 2012, The Conversation. The Scottish Government Social Research, Risk and Protective Factors for Suicide and Suicidal Behaviour, a Literature Review, 2008. And E.C. Harris and B. Barraclough, Suicide is an Outcome for Mental Disorders, a meta-analysis, 1997, 170, the British Journal of Psychiatry, 205 to 228. And Hunter and New England Area Health Service and A. 2009, Volume 74, New South Wales Law Reports, page 88. Alternatively, Volume 2009, New South Wales Supreme Court, page 761. The Mental Health Act 2013, Tasmania, Section 7, Subsection 2. This formulation is similar to that found in the Western Australian and Queensland legislation and broadly reflects the common law formulation for decision-making capacity. Mental Health Act 2013, Tasmania, Section 40. As for the Victorian and ACT legislation, a refusal can be overridden in limited circumstances, such as Section 70 of the Victorian Act and Section 58, subsection 2BII of the ACT Act. As for the S. Callahan and C.J. Ryan, New Approaches to Mental Health Law, Rising to the Human Rights Challenge in Compulsory Treatment in Australia. 2012, Volume 46, Australian and New Zealand Journal of Psychiatry, page 611 and 619. And the United Nations General Assembly, A/HRC/22/53, Report of the Special Rapporteur on Torture and Other Cruel, Inhuman, or Degrading Treatment or Punishment. Juan E. Mendez, 1st February 2013.